Welcome to Your Family's Health, the program that focuses on healthcare issues with unique and different modalities for taking charge of your health today. Experts talk weekly with our continuing roster of guests from around the country and right here in Nassau County to keep you up to date on the latest health issues and trends. Take care of your mind, body, and soul. Spend the next half hour with the voice of Nassau Community College, 90.3 WHPC, and get on the journey to better health.
Hello and welcome to Your Family's Health. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. And I'm here with my co-host, nursing student Joseph Torino. And today we're talking about different options you may have if you're considering weight loss surgery, as well as what happens if you regain the weight after having one of those surgeries. Our guest today is Dr. Rajeev Vohr, who is the chief of Laparoscopic and Bariatric Surgery at South Nassau Communities Hospital in Oceanside, Long Island. Dr. Vohr, welcome to Your Family's Health and the voice of Nassau Community College, 90.3 WHPC.
Thank you very much for having me.
Dr. Vohr, tell me how it is that you decided to get into the weight loss aspect of surgery.
Okay. Well, when I started at South Nassau 20 years almost to this date, I was doing advanced laparoscopic surgery. Weight loss surgery or bariatric surgery was being done, but at that time it was being done open. And even though we knew of the benefits and the efficacy of it, the risks of doing these surgeries open far outweighed the benefits. And that's, as with the advancement in laparoscopy, we started with procedures like doing the gallbladders and then hernias and then more complex operations like removal of portions of the intestine. The next frontier was to start doing bariatric surgery laparoscopically. And we started the program at South Nassau about 18 years ago. And what really is amazing is that we can do these complex surgeries now in a very safe and reproducible manner, and the risk involved in doing a major bariatric surgery is almost the same as the risk of just taking out a gallbladder in this day and age. So that really is how laparoscopic bariatric surgery involved and how my involvement started with it about 18 years ago.
So surgery is usually the last option. How long does someone have to claim to be watching their diet and exercising before you choose this option?
So there's no finite time period. I think now there are certain insurance requirements, and on average they require about a 6 month of monitored weight loss where it's documented that they have to been working with a dietitian or their primary care physician as far as making an effort to lose the weight non-surgically.
And is there like a certain weight that you would have to be? Is there a cutoff limit or?
So there are certain criteria which are established by the National Institute of Health, which all programs have to adhere to.
Okay.
And they're really based on two factors. One is the BMI or the body mass index, which is essentially a formula between the height and the weight. So it's really your weight in kilograms divided by your height in meters square.
Okay.
Anything above 25 is considered obese, mildly obese. Anything over 30 is moderate obesity, and over 35 is severe obesity. In order to be a candidate for weight loss surgery, you have to have either a BMI greater than 40 or a BMI greater than 35 with established comorbidities. Comorbidities are conditions, the medical conditions like diabetes, hypertension, sleep apnea.
And what would the comorbidities be that you would be looking for the surgery?
Those are the ones which I just alluded to.
Okay.
So basically the commonest ones we encounter are diabetes or hypertension or sleep apnea, or could be arthritis. So hypercholesterolemia, increase in your blood cholesterol. So these are all the different medical conditions which fall under the categories of comorbidities.
Mm-hmm. So you talked about comorbidities. I know that as patients have multiple comorbidities, makes them weaker or makes them more predisposed to having catastrophic surgery during surgery.
Correct. Yes.
So when is it that patients are steered away from this type of surgery because they have too many comorbidities, or that comorbidities are too catastrophic for them to endure the surgery?
I think your question is it ever a point where it's prohibitive to do it?
Correct.
So each patient is put through a pretty extensive, rigorous testing, which includes cardiac evaluation, pulmonary evaluation. We do an endoscopy, psychological evaluation, radiology, and blood tests. And really, it's the evaluation of this entire testing will tell us whether it's safe to proceed or not. Mm-hmm. If somebody has a prohibitive risk from a cardiac point of view, meaning their risk of having an untoward cardiac event is too high, and the cardiologist tells us it's not safe to put them under anesthesia, then obviously we will not proceed. So once we know that a patient meets the criteria, then we start the process of educating them about the risks and benefits of surgery, and then simultaneously start the process of their preoperative evaluation to see if it's safe to proceed with surgery. And then during the course of the next 6 months, we meet them on multiple occasions to review the results of this testing, and then come to a decision whether it's safe to proceed or not.
Are there medications that you prescribe patients before even considering surgery, bariatric surgery? Do you try with medications to reduce weight, lifestyle changes before the surgery?
So what we do when we evaluate patients is we have a discussion with them about the different options, and we educate them. And really, all patients have options which are non-surgical. So we always tell them, if they've never tried anything in the past, then the first thing they should do is try a structured weight management program. Certainly a lot of patients are familiar with the commercial programs, whether it's a Nutrisystem or Weight Watchers. We have a well-established structured program which comprises of nutritional evaluation, meal replacement, psychological counseling. So that is the first thing they can start with if they've never done anything before. Other options which they certainly can consider if they're not considering surgery is something called a gastric balloon. A gastric balloon is a device which is non-surgical. It can be placed very easily in the office setting or via endoscopy, and we inflate the balloon. It stays in the stomach. They follow up with our multidisciplinary team for 6 months. That's the duration the balloon stays in the stomach. And at the end of 6 months, we take it out. And then it's a surgical option. So when we see patients, we're not really talking to them initially about weight loss surgery. We talk to them about weight management, because that's really what I feel strongly. We're all managing our weight, and surgery is one tool. So it all depends on where the patient is in the spectrum of what they have tried and not tried in the past.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard from the nursing department here at Nassau Community College. I'm here with my co-host, nursing student Joseph Torino. And today we're talking about weight loss surgical options with Dr. Rajeev Vohr, Chief of Laparoscopic and Bariatric Surgery at South Nassau Communities Hospital in Oceanside, Long Island. So, Dr. Vohr, Joseph has a question.
Yeah, so that was really interesting when you were talking about there's other options just beside the lap band that you also consider. I also, when going researching into this topic, I came across that there's also sleeve gastrectomy, gastric bypass, revisional weight loss surgery. Would you mind kind of just helping me clarify the differences between those?
And the lap band, yeah.
And the lap band,
Sure.
absolutely.
Okay, so again, as I said, so now we're discussing the surgical options
Yes.
for weight loss surgery. So if you look at in the last 3 decades, the 99% of the patients would have encountered one of the 3 surgeries you just alluded to, which is a lap band, a gastric bypass, and then a sleeve. And I'll talk in some details about each of them. So let's talk about the lap band first. The lap band's been around for about 20 years, and it simply is a band made of silicone, which is wrapped around the top portion of the stomach. The surgery is done in a very minimally invasive manner, and it's a quick recuperation. Unfortunately, there has not been long-term success with the band, and at this point, there are very few bands which are being placed. Probably less than 1% of the surgeries done nationwide are less than lap bands. And just to put things in perspective, about 10, 12 years ago, that number was about 30 to 40. So what we now know is that a majority of these bands end up being removed. They slip or they prolapse because of the repetitive nature of the eating and vomiting, which these patients, the pattern they develop. So for the purpose of discussion, very few new patients would be considering the band. And now with the advent of the balloon, if somebody doesn't want to consider a procedure like a sleeve or gastric bypass, which involves cutting the stomach, and the gastric balloon is certainly an easier option. It doesn't involve any surgery like the lap band and can be easily removed and doesn't leave any scarring around the stomach once it is removed. Then, so basically, currently, the 2 most popular and viable options left for the laparoscopic surgical options are the gastric bypass and the sleeve gastrectomy. In a gastric bypass, there are 2 mechanisms of weight loss involved. We divide the stomach into a very small pouch above, and then the rest of the stomach is not removed, but it's disconnected from the food loop. And then we reroute a portion of the intestines and connect them to the pouch. So essentially, obviously, the patients have the pouch has a very limited capacity of a few ounces, so they're going to get the feeling of fullness after eating a small amount of food. And then secondly, because of the bypass component, there's what we call malabsorption. So there's going to be less calories absorbed because we've bypassed a portion of the intestine. So. Okay. And the bypass has been around for 3 decades with good, predictable results. There are certain nuances which we started seeing in these bypass patients. They are prone to develop ulcerations in the small portion of stomach if they ingest anything which irritates the stomach lining. So anytime anybody takes non-steroidals like ibuprofen or even aspirin, excess caffeine intake, and smoking, they promptly develop ulcers. Second, which I think is a very important thing, is what we call the dumping syndrome. There's no reservoir for the food to be stored. So there's a very rapid transit of food, and that can cause the dumping syndrome with low blood sugars. So, and then thirdly, long-term vitamin and nutritional deficiencies. In a sleeve gastrectomy, what we're doing is gastrectomy means removal of a portion of the stomach. So, and the sleeve is essentially what the shape the stomach takes, like a sleeve of a shirt, when we remove about 2/3 of the stomach. So essentially it comprises of, again, the first part is it's going to limit the size of stomach you have and, again, give you the same feeling of fullness. And secondly, equally importantly, it has what we call a hormonal component, because by removing the top portion of the stomach, which is called the fundus, where the hormone ghrelin is made, it reduces the production of the hormone ghrelin and thus causing the metabolic benefits and the resolution of their comorbidities like diabetes. So it has a dual mechanism, restriction and a hormonal mechanism. The advantage of this sleeve is there's no altering of anatomy, there's no foreign bodies involved, and the sphincter is intact, so food exits the stomach in an orderly manner and avoids the dumping syndrome. So currently, the most prevalent surgery being done is the sleeve gastrectomy.
So it sounds like the sleeve gastrectomy is the most prevalent surgery that you recommend at this point.
Absolutely. Again, we analyze each individual scenario, and there may be certain scenarios where we may recommend, a gastric bypass or some other procedure. But for the most part, majority of the patients will be candidates for the sleeve gastrectomy and prefer that over the other options.
So how long has the sleeve gastrectomy been performed in comparison to the other surgeries, the gastric bypass?
So let's say if the bypass has been around for about 30 years, the sleeve's been around for about 15 years.
15.
So we have excellent long-term data now about the results of the sleeve gastrectomy.
Now, would you say after the sleeve gastrectomy that patients have less, as you said, less malabsorption, less ulcerations, less problems with dumping syndrome and vitamin deficiency, that we're seeing better side effects after the surgery? Absolutely.
From a side effect profile, it's much improved over both the band and the bypass. It's still very important that the patients follow up very diligently with us and adhere to their nutritional guidelines and taking the vitamins, but we certainly do not see anywhere near the nutritional and vitamin deficiencies which we would see with the gastric bypass. As you said, it avoids all the pitfalls of the bypass, like the marginal ulceration and the dumping syndrome. One side effect of sleeve, which we make patients aware of, that they may have some element of gastric reflux, and a small percent of patients may require some medications to minimize the reflux. But the beauty about the sleeve is anatomically and physiologically, it's the best option available.
Tell me, doctor, is there an age criteria? I know that you talked about the BMI, but is there age criteria? How old or young?
We only offer it on adults, so the age has to be over 18 in order to be considered a candidate for surgery. If it is being done in adolescents, it should be done in the setting of a controlled trial or a protocol. So 18 is the minimum age needed. We do not really have a cutoff age as far as what is the oldest we can do on. I think it's on a case-by-case basis. I think the oldest we've probably done is about 75.
Okay.
And it really depends on how the patients are more physiologically than just their age.
Mm-hmm. So tell me, with the patients who are getting the gastrectomy, how long is it before they're actually seeing a weight loss?
So actually, the process of weight loss starts well before they've even had the surgery. So I always tell patients on the first encounter is what would be the day they want to get started to start getting healthy, and if the answer is today, then that's when we start. So we start with the baby steps. We initially ask them to make some slight modifications in the foods they're eating, and the amount of water they consume, or the amount of activity they're doing. So we create that general awareness, and they start losing the weight. Then about 2 to 4 weeks prior to surgery, we put them on a very structured liquid diet, which is basically high-protein shakes. It does two things. It gets them to lose the weight and gets them mentally prepared to continue that after surgery. And secondly, it shrinks the fat in the liver inside, thus enabling us to do the surgery in a very expeditious manner, and allows us to do the surgery laparoscopically without having to cut them open.
Oh, wow, that's great.
So I was just going to ask, so I know before the surgery you said you give them protein shakes to better prepare them for it.
Correct.
So after the surgery, how soon can their diet, I wouldn't say resume to normal, but be altered to the new healthy diet that they can follow?
Correct. So again, for the first few weeks, again, we encouraged, the main thing is concentrating on their hydration with water and their proteins with the protein shakes. And then we started introducing other high-protein foods like yogurts and cottage cheese and eggs. And so they work closely with a nutritionist. So by about the 3 to 4 week period, they start introducing foods, and then gradually, in increments, they introduce more foods every 2 to 4 weeks.
You're listening to Your Family's Health on the voice of Nassau Community College, 90.3 WHPC. My name is Dr. Jeanine Cook-Garard from the Nursing Department here at Nassau Community College, and I'm here with my co-host Joseph Torino, nursing student. And today we're talking about weight loss surgery and surgical options with Dr. Rajeev Vohr. He is the chief of Laparoscopic and Bariatric Surgery at South Nassau Communities Hospital in Oceanside, Long Island. So, doctor, this is very, very interesting. What is the incidence of people who have had the gastric surgery who come back gaining or regaining the weight that they were trying, that they lost? What is the success rate?
Okay, so what you're asking about is weight gain or recidivism. So on average, what we expect is about a 75% excess weight loss in the first 12 to 18 months after surgery. So by excess weight loss, I mean if a patient's ideal weight is supposed to be 150 and they start at 250, they need about 100 pounds to lose. So they'll lose about 75 pounds. That's the expected weight loss. Then a lot depends on the patients and how closely they participate in the ongoing support groups and follow up. There will be a small subset of patients who will have recidivism. It could be an event in the family, a setback or something, and then food being the comfort. So they regain. They don't regain all the weight, but if somebody's lost about 100 pounds and then we'll have patients who'll say, okay, I've gained 15 or 25 or 30 pounds. We obviously encourage them to come back and get them back on track. So we have a back on track program, which we absolutely encourage them to access us for. And then we restart the process of educating them, again, highlighting the do's and don'ts. Some of them may need to get back on some of the protein shakes to get them back to lose some of the weight they've gained. So we'll certainly see some element of recidivism as the years progress, but I think it's very important for patients to know that they need to nip it in the bud. So if somebody has gained 10 or 15 pounds, we can easily get them back on track and get them back to the way they felt initially after weight loss surgery.
So if they say they missed that point, that 10, 15 pounds, and they don't get back on track right away, are there surgical options? I was reading something called revision surgery that would maybe bring you back in that direction. So answering your question, if somebody has regained the weight to where they are now, again, morbidly obese, and they meet the criteria for weight loss surgery, which is the earlier one which I had alluded to. So the criteria for revisional surgery is the same as the criteria for primary surgery, meaning you have to have the BMI greater than 40 or BMI greater than 35 with established comorbidities. So if a patient has done that, we absolutely can help them. Okay.
It's almost like starting with the basics again. We get them back into the program, start having them working with the nutritionist, the psychologist, try to analyze and help them analyze as to what was the deviation that caused them to change their habits or gain the weight. Once we address the issues, then we discuss the different options. Again, we can have them lose the weight non-surgically by the weight management program. And if they certainly want to access surgery, there's lots of options for patients who've had surgery. So the commonest type we will see is, as I alluded to, all these patients who have had lap bands. There's tens of thousands of patients who have had lap bands and who have regained a good amount of weight. In that scenario, we will offer them to remove the band and have a sleeve gastrectomy as a revisional procedure.
Okay. So it would almost be like a replacement, changing what was there. Okay. And you also have some free seminars coming up that people can attend if they want more information on this?
Absolutely.
And your website.
Yeah. The first step towards this is getting educated. We absolutely encourage patients that they attend either one of our live seminars, which we have every month at South Nassau Communities Hospital in Oceanside. If they cannot physically attend one of these seminars, they can certainly go on the website at southnassaubariatrics.org or newyorkbariatrics.com and access some online educational seminars in lieu of attending a live seminar.
And these are held all year?
These are held once a month all year, and the online education is available all year round. On the websites, as I said, they can go on southnassaubariatrics.org or newyorkbariatrics.com. We certainly are happy to meet with them on a one-on-one basis at our hospital and at our office and go over all their different options with them also.
And what can people learn if they log into the website?
I think they'll get a very comprehensive education about the different options they have for weight management, the risks and benefits of the different options, and it helps them make a decision as to what they should consider.
So if you had to leave us with just 2 words about bariatric surgery, what would you say, doctor?
So I think my parting advice is to the patients that obesity is a disease. It's not their fault. They're made to feel by their family members and by their physicians that it is something which is under their control and they should be able to lose their weight on their own. We want them to feel that this is a disease and they certainly can access help for it. Where at the end of the day, they are going to be in control, but we'll be giving them a tool with which they can succeed and feel good about themselves. So don't hesitate. Feel free to attend one of our seminars or call our office at 516-374-8631, and we'd be glad to help.
Thank you so much, Dr. Rajeev Vohr, for being here with us, Chief of Laparoscopic and Bariatric Surgery at South Nassau Communities Hospital in Oceanside, Long Island. This is Dr. Jeanine Cook-Garard from the Nursing Department here at Nassau Community College, along with my co-host, Joseph Torino, nursing student. And we want to thank you, our listening audience, for tuning in to this edition of Your Family's Health.
We'd like to get your feedback on your family's health. Send your comments by emailing them to whpc@ncc.edu. Podcasts of today's show are available on iTunes, Android Podcasts, and Spreaker. This program was produced at the studios of Nassau Community College in cooperation with the Nursing Department. Join us next week for another edition of Your Family's Health on the voice of Nassau Community College, 90.3 WHPC.